to you to talk to us about the topic of can social prescribing work for the children's sector.
Thanks a lot for that, and good morning to everybody. This is going to be an introduction to social prescribing. I'm going to give a broad overview of what social prescribing is, its potential benefits, and why it's relevant to voluntary organisations working with children and young people. I'm also going to give you some examples of where it's been used and what it's achieved already. Now, this is only an introduction, so at the end I'll also provide you with some links that will help you find out more should you wish to do so afterwards. And just before I start on this, I just want to quickly explain NAVCA's role in this. As I've already said, NAVCA are the National Membership Organisation for Local Infrastructure Charities, such as CBS's or voluntary actions. Now, where social prescribing has worked well, there's often been a voluntary organisation playing the bridging role between commissioners and voluntary organisations, especially some of the smaller ones. And this has often been a local infrastructure organisation, one of NAVCA's members. So, what is social prescribing? When we say social prescribing, I always have to say it is an awful, awful name, but it's used largely because it's something that commissioners understand, and that's who we're trying to talk to. Now, it's a major issue in health at the moment, but it's a very, very simple idea, and it's something that charities and community groups and everyone listening here, it's something we've always done. Social prescribing is just about trying to get people to improve their own health and well-being by referring patients to social services available within the local voluntary, community and social enterprise sector. It's just about linking people up to activities in the community that they might benefit from. And get them to get involved in non-medical sources of support rather than doctors, GPs or whoever just always thinking there's a clinical solution to everything, whether that's more medicine or more surgery. And as with most things at the moment, the need to make money go further has been a big reason why it's an idea that's really growing. But for charities, we should be more interested in it as a way to provide better services for the people we're here for, and as a way to get our services valued and, let's face it, commissioned. And I think it's also connected to the personalisation agenda and the increased understanding of the value of preventative services. And some commissioners are also seeing how it can create better outcomes. So, a bit more about what social prescribing is. I mean, and why we should be using it. I mean, it's got the potential to help people manage their own health and well-being, reduce isolation, and develop community cohesion. In turn, this will reduce unnecessary hospital admissions and give GPs more time to provide services for some of the more vulnerable people. Social prescribing also fits Better Care Together strategy, which aims to reduce the amount of activity carried out within hospitals and helps address the national issue of an overstretched primary care system, which I think we'll all be aware of, I mean, especially with the recent news about winter pressures. Further, whilst referral into services delivered by charities and community groups will not always be cost neutral, and when I say they're not always cost neutral, obviously what you do costs money and that's got to be recognised. It's still nearly always cheaper and more effective than a 15-minute consultation with a GP for non-medical issues. From the voluntary sector's point of view, supporting patients referred to your organisation helps you to demonstrate your value and positions your group as central to achieving large-scale positive health outcomes. It's a way, social prescribing is a way that the voluntary sector is increasing its role in delivering commissioned services in health and care. It really helps the voluntary sector play to its strengths, and it's evidence that it can provide better health outcomes and make money go further. I mean, I really believe that social prescribing is tailor-made for voluntary and community sector-led interventions, and it does result in better outcomes for people with long-term conditions and carers, more cost-effective, as I've said, and what's quite interesting as well from a voluntary sector point of view, it can lead to a wider, more diverse and responsive local provider base. So that's all well and good and very interesting, but probably the most important thing. So why is this relevant to you, people working for charities involved in the children and young people world. This is just for health. Well, firstly, there's a lot of crossover between health and children's work, so I suspect a lot of you will be working already in the health field. You may have already been involved in social prescribing. Secondly, there are links between social prescribing and the early intervention and preventative agendas, where the voluntary sector is so strong, and work that there is being led by charities in the children and young people's field. And I think the approach has echoes in the Troubled Families programme. A third reason is that some of this, and some of the ideas and the principles, may be possible to replicate, and some of it may be possible to be adapted. And some of the evidence that's coming from this work may be useful for you to use as well. Fourthly, I think it's quite interesting for your work because it's a way that communities really understand what the voluntary community organisations do. They really get the value of your work. And that's even if the work you're doing isn't primarily seen as health work. And finally, if it's not all those four things, maybe and hopefully this will just be interesting and it'll be useful for you to see how charities involved in health and care work are tackling similar issues to some of the issues you're facing. So I now want to just look at so I've talked about what it is very briefly and given an overview of that. And I want to talk about, well, what does this mean in practice? And I've got 3 examples of where social prescribing has been done. And the first one I'm going to start with is Rotherham. And this is probably the most well-known and celebrated example of social prescribing. What's really made it well-known, and people talk about it a lot, is that they got Hallam University to evaluate it. This academic evaluation has really provided great evidence and proof that social prescribing can not only save money, and it's got figures of how it saves money, better outcomes. And so this example has really helped people arguing for this way of doing things to not just give a theoretical argument, but to actually have really strong evidence to back up the point. The pilot was led by voluntary Rotherham, who got voluntary sector advisors working within GP practices, which is quite interesting, and there's several examples of places doing this. He also put together a menu of services, and this menu had 33 different services and activities provided by 26 voluntary organisations. And all the organisations providing these services received funding for doing them. And the sorts of services are things around befriending, or it could be arts groups or culture groups. It's really a lot of it is around social isolation, or trying to deal with things at a community level rather than just medication. And as I said, the evaluation showed that not only did they save money, but it resulted in less people needing hospital treatment, which is really important, as I said before, about the pressure the NHS is facing. And that, the figures here, when you look at the progress of self-management, the reduction in A&E, the reduction in inpatient and outpatient appointments, you can really see why NHS organisations are becoming interested in this approach. Now, and you'll see that at the end, it actually saved money as well. Now, there's a lot more information from the evaluation, and there's a link at the end of this presentation, so you can see more of that. A second example of where social prescribing has been used is in Essex, and it's a project called Essex Connects, which began as a 4-partner collaboration project initiated by the local infrastructure organisation and now covers 7 districts of Essex. And what this shows is there's not just one model of social prescribing, so here's another way of doing it. And here a lot of the work is about helping GPs and individuals understand the menu of services that local charities can provide. And they've got things like an 0800 telephone helpline, an online directory. They have outreach in clinical and non-clinical settings. And some of this, I think, shows just how simple some of this work is, and actually just how much, it's just a lot of it, although we call it social prescribing, it is just common sense. And importantly, organisations that are part of this need to meet agreed quality standards. Those involved in this work in Essex say that this has been important because it increases the credibility of the services. Something that is important when working with commissioners who can at times start off a little sceptical. The next one, and the third area to look at is Calderdale. Now Calderdale is in West Yorkshire, it's the area around Halifax. Now here they also use a directory to help GPs, voluntary organisations and individuals understand all the services that are available, and they make this public both online and as a hard copy. And again, it's quite interesting because here they've extended it a bit, so it's not just about GPs, they've also got other organisations, the council and the police, who can look at what groups are. So there's obvious benefits for the voluntary sector here. In Calderdale, social prescribing is used to help GPs refer patients with social, emotional or practical needs to a range of local non-clinical services, often provided by the voluntary and community sector. And this again is counselling, befriending, gardening, lunch clubs, and things like music or drama or arts. And quite interesting, they recruit and train volunteers to work within GP surgeries, to do some of the work with one-to-one work, trying to get people to work with patients and local people to see what services are best suited to them. And also that they've had similar experiences to Essex, which I think it sums up best in this quote here, which says, GPs need to know about them, be confident about them, and know what patients can access, and know that patients can access them, is to what services, and be confident in the services provided. Whilst there are no clear pathways or indicators, GPs prefer to refer patients into NHS services, and that just shows that that is what we're up against. GPs will always default back to using NHS services. So if we can get a way to get GPs to understand the value of voluntary and community services, then it's really useful for us and obviously helps us maintain our services to the people we're here for. So that really is a quick run through of what social prescribing is and how it's being used. If you are, as promised, if you are interested in this and finding out more, here's a good place to start finding out some more. The Guardian article at the bottom there is a very short article. If you've only got 5 minutes, it's worth reading that to just get more of a human idea of what it's about, because that's an article written about, a lot of it's about a fishing group in Newcastle, but it gives it from, not just from the provider's side, it's actually from the person who's getting the service. It gives an idea there. And if you're interested in how it's being used in different areas, here's just 5 areas where they're using it. I mean, there are a lot more, but this is probably a good starting point for you. So if I can thank you for that, and really it's a chance now to have questions or comments, and also I think it'd be quite interesting to hear any thoughts about how this could be adapted to the work you're doing. So thanks a lot for your time, and I look forward to getting questions.
Well, thank you very much, Barney, for a really interesting and informative run through social prescribing. I think there's some great further reading and further research there, but actually it stimulated a lot of questions. I've got several coming in here now, and if you are still in listening mode, do send through your questions. I'm going to try and group these somewhat, Barney. If I start off with the first one I've got here. So this question asks, a lot of social prescribing has been focused on supporting older people. Is this really where social prescribing will flourish, or can it be adapted?
Yeah. Do you want me to answer that now?
Yeah, I think that's the one that really I've got on older people. I've got several here that ask about timescales for change, etc. Maybe we can come back to that next.
Okay.
And yeah, quite a bit about the money. So yeah, if you could answer that one about the real focus on, and we know that from the NAVCA, there's a really great toolkit that NAVCA produced, that there were some strong examples on services for older people. So the question is this where social prescribing will truly flourish, or can it really be adapted?
I think it does suit a lot of the work with older people, largely because where social prescribing comes into its own is when it's working with people with long-term conditions and people who are regular users of NHS services. So for older people, there's an obvious tie in there. However, that's not all it can do. I mean, there's been a lot of work using social prescribing to help people with mental health issues, and the Guardian article about the fishing group in Newcastle is a lot about that. But I think there's also, you'll know, and people listening will know of groups of people or individuals they work with who are regular users or regularly need to have health support. It can be used for them. I think what I'd be quite interested in is, at the moment, because I think it's easiest for people to think about how it can apply to older people, that's where a lot of the work's being done. I actually think how it could be used more with children and young people is really interesting, and I actually think, I'm hoping that the people listening, you've got the expertise on this, and I'd really be interested in how you think this can be used, or whether there are ways you can adapt this into the work you're doing to make your services more available to people and better valued by commissioners.
I think I've got another related question really here, Barney, because it's on the topic of timescales, and the question is along the lines of the timescale for change, and that this sounds like it's a longer term solution-focused approach that doesn't necessarily sit alongside 1 year and 2 year funding streams. And then a question: how long does it actually take to set up one of the social prescribing projects as have been described here today?
The answer is it can take a long time. The Calderdale one is quite interesting in that it was set up and a lot of the work was done by Voluntary Action Calderdale. And whenever I've spoken to people from Voluntary Action Calderdale, and we say, well, how did you go about doing this? And they say, you know, or how can we do this in our area? They say, well, start 8 years ago, because that's how long they've spent working with local commissioners and local health organisations. And I say local health organisations because the names were different when they started. They've probably gone through 3 or 4 different reorganisations since. And there aren't any shortcuts, unfortunately. It really is, often it's where it's worked because local relationships have made it work. And that's, I think, for a lot of people that's probably the wrong answer, because that's not what people want to hear. I think I think that this is why Rotherham is so valuable, is that what Rotherham can do, and the evaluation, it can help you make a few shortcuts. So you're not starting from scratch, you've actually got some evidence of how it works and where it's worked. But the benefits are not got back in the first year. I'm just going to quickly flick back to the Rotherham slide. And in the Rotherham slide, at the very bottom bullet point, you'll see they're talking about cost reductions over 5 years. You know, and I think they're the sort of scales people got to think about. But I would hope that commissioners have got that foresight, and when we're looking at the problems of funding that the NHS is clearly facing, that should be the motivation to think more than a year, even though the way public services are funded, that is difficult. I hope that's helpful. I sort of feel like I've half answered it and half given a difficult answer.
No, I think that's great, and I do think it's really important, to be honest, that this is not a quick fix, as it's not an immediate project. It's one that it sounds like it starts with community capacity. Perhaps it's a combination of different voluntary sector organisations and other partners coming together to work on a plan that takes a while to come to fruition. So it isn't necessarily in response to a commissioning opportunity, a funding stream. It's a project, a plan that takes a while to grow, and then going for the funding is after some of the project outcomes have been set out and potentially some of that community capacity has already been recruited. It certainly sounds as though it's a longer term commitment. So social prescribing for local communities and for ways of working rather than short-termism. Can I turn to my other panel members? Peter, have you picked any questions up from our webinar messages coming in?
Yeah, there's an observation here that I think is probably the first link to the sector, which is quite interesting. There's a comment here about health visitors and whether they are, in fact, the bridge and the link, particularly to early years services and whatever, that will be trusted and respected with by doctors. They'll have the link with GPs. There's almost a complete bridge there between what is already established in some areas, and perhaps there could be some more experimental work there. Barney, I don't know if is that the sort of way that you see it linking forward into children and young people's services?
I think that's a really interesting idea, and I'm always pleased to hear health visitors mentioned, as my mum was a health visitor, so it's good. I think that is really useful because it's about having people who can be the bridge, and a lot of the examples I've used, a lot of the bridging work is done by the voluntary sector, but actually there are important public sector people who can equally do that work. I think that's quite interesting.
The other question, there's another question here, which is, I suppose, a bit more about the process as to who the prescribers are, or how the funding is linked. I mean, is this process, as you say, is it led by local commissioners? Is it those people that are looking for innovative ways, or is it really up to the voluntary sector to package it, put it together, and present it to the commissioners?
The examples I've used, a lot of making it possible has been because it's been the clinical commissioning group, the CCG, who have been the ones who have put the money up to make it happen. And where it's worked as well, the CCG has recognised that you need to invest to set up you need to invest in the infrastructure of the voluntary sector. So you need to get some sort of training involved, or you need to get something to be able to fund some sort of quality standards. And when I talk about quality standards, a lot of that is around GPs feeling confident that they're sending people to safe services. And I think working in children and young people's world, the idea of safeguards is obviously something that is in every, you know a lot more about than me. So I think the CCG can be the sort of deal breaker, but I think it is based on the relationships between the commissioners, the decision makers and politicians at times, and the local voluntary sector. So it is quite important that I think what's key for the local voluntary sector is that they're not going one by one. I think there has to be some sort of work within the voluntary sector to get a common voice, to work together, to try and work out what it is they want. And obviously, I would say this would the local NAVCA member can be part of that. But also, there are some quite large charities who do quite a lot of subcontracting who can also help with that, I think.
There's another interesting comment here from a youth perspective. Obviously, a lot of local authorities have severely cut back their youth services and they are even commissioning, some out in some places. I mean, Norfolk, for example, I think is giving each local geographical area a sum of money rather than providing services. And also, a lot of local authorities are only doing targeted work, and now realising that once young people come out of targeted work, that there's no universal services to go to. And I wonder if that's another, potential gap, that if you were a collective of youth services, that actually you might be going to the local authority and saying, these are the services, with your support, local authority, we can pick up your universal provision for you. These are services that we can offer to young people, particularly those that you've referred to targeted services, and they're now looking at the next step.
Yeah, I think that sort of approach is really, not just in this, but I think that's increasingly going to be the approach that will bring benefits. We had a conference fairly recently, and one of the speakers talked about a concept of co-opetition, and the idea that at times you're in competition, and at other times actually you've got to cooperate with people. And actually this should play to the voluntary sector's strengths, because we all do certain things really well, and actually by working out who can do what part of the service best and playing on your strengths, it can work. But obviously the difficulty is the way the funding is, the way a lot of funding is set up, is that funders want want to get you in competition with each other with this idea that competition will drive improvement and better value for money, and it's not true. But actually, so I really like this idea of co-opetition, where there's a bit of competition on some things, but actually you're working together a lot of the time as well.
No, Barney, one of our participants is just asking, is social prescribing about providing a service on the cheap and getting the voluntary sector to replace the state? Just what do you think about that? How would you respond to that?
I think this is one of the biggest sort of dilemmas that a lot of charities are facing at the moment, is that increasingly, as the state withdraws from providing services, we're having to come in. Now, are we replacing the state? I think there's a real issue at times when volunteers are being used to replace paid workers. I think from a commissioner's point of view, there's a real attraction that this is a way to save money. And that shouldn't be ignored. I think that is important, and I think all charities also sort of have a bit of an interest in making sure that funding is used efficiently. However, our motivation should be, we should always think about what are we doing, why are we here? Maybe not quite so philosophical, but we've got to be here to deliver services to the people that we're set up to help. And if this is a way of doing it, if this is a way of getting our services valued, getting our services better understood, and crucially, getting better outcomes for the beneficiaries that we're set up to help, then we shouldn't have a problem with it. It will save money if done right, but it isn't a cheap thing. I mean, going back to Rotherham, where it will save money, but it won't save all the money that NHS needs to save. And it does require investment in services, and the services delivered have to be funded. So it can save money. I think always when charities are getting involved in this type of work, they need to think about why they're doing it. But it's not just about doing it on the cheap, it is about better outcomes.
Okay, so I think that's a very firm no, this isn't about providing services on the cheap, because Barney's just alluding to the fact that actually running a really strong and effective volunteer model actually means investing in that volunteer program. It doesn't come without costs and resources, and certainly this isn't about voluntary sector replacing the state, but it's perhaps taking services in the direction of prevention. So we're all familiar with working on early intervention, but it's a step before that, really looking at what is likely to make the biggest difference in a preventative model, which could be a huge benefit for the social prescribing model.
There's a question a couple of questions coming just while you've been talking, and this is really relies on your knowledge, Barney. In the models that you described, has funding come directly to the VCS for social prescribing? Sorry, is that part of the deal? And the second part of that is, is it likely to be sustainable enough to enable them to offer quality services? If you're perhaps recruiting paid staff to deliver services on the back of that, how does the future lie? I mean, are commissioners commissioning for 1 year, 3 years, 5 years?
Yeah, I mean, a lot of the work at the moment has been pilots or sort of, it's been to test and see how it works. What is quite usual in the models is that a sum of money will be put aside, and it's things like Rotherham or Calderdale, where they've got a suite of services or a menu of services. Often the money will go to the organisation that's developed, that's put together the menu, and they'll be the voluntary action Rotherham or voluntary action Calderdale in those two instances, and then the money will then go down to the individual charities as they deliver the service or community. And one of the beauties of this is of this work is that actually very small organisations can have their services commissioned who would normally not be in that game at all. So the money will go to the voluntary sector, normally held by an intermediary. And I think what I would say is it works best, but not always, it's not the only way, but often it works best where the person who's put together the menu of services isn't also providing services. I think that creates a conflict there. Now, I think, is it long-term funding? I think Rotherham are funding it, continue to fund it because of the success of it. I mean, you never know how long things are going to fund it. I think it's right to be cautious that we often see pilots being done where things are well funded, gets great results, and then people look at that and then try and replicate it on the cheap, and they don't get the same results, do they, inevitably. So I actually think there's a genuine interest in getting better health outcomes and saving money by using the voluntary sector, and I think this is one way that that's being done in health. I think it'd be quite interesting to, I think it does link with lots of the preventative or early intervention agenda that's being led in the children and young people's arena. I think there are real links there, maybe the two sides of the same coin, but I think there can be money there, but I don't think we should go into it naively.
Yeah, I think
well, one question is, so we've got one question here is very specific on costs. Do you know how much it actually costs to run one of the example projects? In fact, I think on your slides you did have a value of £1 million on, one was a £1 million pilot. So how much it actually costs. So that example there we've got, so the Rotherham, £1 million pilot, so there were 5 advisors, 36 GP practices. I'm just wondering how many patients and how many people that service actually extended to get a sense of scale and just value, essentially. Yeah.
I mean, that was quite big because Rotherham, I mean, that 36 GP practices, I might be wrong here, but I'm fairly certain that covered the whole of Rotherham. Now, Rotherham is a town of about 200,000 people. Yeah. So that's quite a big area. And that was quite a big amount of money as well. There are other examples. I'm just flicking through some notes. I can't quite find. But I know there's one area where they started off with just £60,000 on a lot smaller scale to see how it goes. Yeah. So I think the message is, if you can get £1 million, great, go for it. But I would hope that people don't feel that you've got to start with £1 million. I think the £1 million you're looking at quite a large town. If you go with just one GP's practice, obviously you can scale that down, and you.
Yeah. Yeah, but then it looks in this Rotherham example, there's some great impact figures there in terms of reduction in A&E attendances and inpatient stays and so on. So we really take that onward and further. It's just about people's just sense of emotional well-being and positive mental health by being well rather than in hospital. That must have brought some longer term benefits that aren't necessarily reflected here, but that potentially will only be achieved by a place-based approach. So if this really was looking at Rotherham as a town and all of the GP practices, it's possible then to attribute some of the the population level change and behaviour change to the investments in social prescribing. That might be trickier, don't you think, if perhaps this example was just with one GP practice?
Yeah, I think you would obviously get be a lot harder to work out what the social value that you're achieving is on top of things, and it'd be a lot less social value, I think, as well. So I think it's always better when you do have the bigger areas covered in this way. But I think to get it started, it may be that you have to start small and start with places where, and I think even in those smaller projects and where it's been done on a smaller scale, I would hope that the cash benefits of the commissioners, get them quite quickly, which will encourage them to carry on with it. And you know what it's like with the public sector. A lot of the time they're sort of looking over the shoulder, seeing what other people are doing and why they're doing that. So it is, I think, hopefully, it is about getting more people involved in this work, and so the benefits are seen wider. Because what's astonishing for me, and maybe I shouldn't be astonished, is that I've looked at the Rotherham evaluation quite closely, and it seems to me straight away it's a no-brainer. And yet, commissioners all over the place aren't doing this. And you have to say, well, if you can spend £1 million and save money, have better outcomes, and you've got the social value, well, why wouldn't everyone do it? And yet they don't do it, which maybe that's life, but it really is. It shows how hard. I mean, I'm going on a bit of a tangent here, but it does really show just how hard it is for the voluntary community sector to get value at times. When it's so obvious once you look at it, but people still don't go with it.
Yeah. In fact, I'm aware of a model, and obviously it's not been described as social prescribing in practice, but essentially, I think there's some real similarities, but it's very much an emerging model at the moment. It's Lambeth in South London, and in Lambeth there are 4 wards, so a very discrete part of Lambeth that are working together on a community-based approach, so very much place-based, community co-production about the models and ways of working, with an intention to improve outcomes, and in particular health outcomes for children, young people, families, but starting with the very early years, so starting with babies, maternity, and children up to age 3. But in Lambeth, the GP practices are at the heart of the project that's emerging, and parent or community champions will be linked to GP practices, and really to act as a guide, as a more informed than signposting, to really talk to families and parents in the area about some of the universal services, some of those services that are already there and provided, making sure that they're making great use of those services with an intention of reducing the A&E admissions, reducing social isolation, domestic violence, improving communication and language, reducing obesity, and making sure that families are making good use of what is university funded, that whole Healthy Child programme that's there for children aged 0 to 5. So there's good investment there with the view that if families take up what's available, that it will act as a protective factor and will mean that outcomes will be supported, even down to school readiness, because a healthy child and family is a child more likely to access early years provision, more likely to be a good school attender. So looking at complete holistic outcomes. And I do think that maybe Lambeth ought to think about describing some of that project, which is a 10-year project, describing that more in terms of social prescribing. Because I think we do need some examples from the children's services world, Barney.
Yeah, I mean, I think that's really interesting. I know also in Lambeth they've done quite a lot of work around mental illness as well, with social prescribing as well, haven't they?
Yes, yeah.
And I think that's mentioned in one of the links on the link there to the Nesta report. I think there's some stuff about Lambeth in there as well, which is quite interesting. So obviously, as a local authority and with the health as well, they must be thinking about these issues quite strongly, I thought.
Yeah, I think the key there is the voluntary sector are very connected to the statutory agencies. So there's a local voluntary sector children's forum that has a good link into commissioning and also helps to influence the commissioning of services at a local level. I think that's probably the starting point, is some of that connectivity. Peter?
Okay, yeah, just comments seem to be drying up, so can I just ask people if they've got any last questions that they want to make, if they could put them in now. a question that came from something you said before, Barney, about intermediaries, and I think I'm just about setting Navka up for another advert here, but we'll let that go by. You said how important it was to have an intermediate service. What sort of examples are there of people that provide that bridge, if you like, between commissioners and local services?
Well, as you say, it's this chance for an advert. I mean, in the examples I've used, that there is an advert voluntary rather voluntary Caldwell in Essex. It's a number of the CVSs there, but the South End Association of Voluntary Services are quite big on that. And I know if you look at some of the other examples, Warwickshire Carver are involved in it, Voluntary Barnsley, Middlesbrough Voluntary Development Agency. But it isn't just NAVCA members. I mean, and although I shouldn't be saying this, I think often a NAVCA member, an independent CVS type organisation, is ideally placed to do some of this work, because they can be an honest broker because they're not delivering the services as well. But there are also examples where it is someone who's involved in service delivery who is also doing it. So I think what you need is an organisation. It's got to be of a certain size. I think vitally it's got to be trusted by both commissioners and the local voluntary sector, and they're the key things really. And there are relationships there. So if people are thinking about this, I mean, it's something to raise with your local CVS or local infrastructure organisation. But it might also be, I mean, if you're involved in children and young people forums within the area where you are, it may be an issue to raise there and see what sort of interest there is amongst the groups, and then see where that can develop and who might be the natural body to take that forward.
Brilliant. Okay. Anna-Marie, have you got any final thoughts before I close?
I think we've really heard about some amazing examples around the country of where social prescribing is making a measurable difference, and also a bit of a reminder there about the importance of knowing the baseline, knowing the starting point, and building that bank of evidence as much as possible. That anecdotal won't always do it. It's really important to think about evaluating and building that story. We are light on the examples on the children's services world, but in part that's what we're trying to stimulate from today. And if those of you listening go away and think of examples that you think fit into the social prescribing model and want to think more about how to really bring that out to the forefront, we want to hear from you. So email, let us know, keep in contact. This is just the beginning of talking about social prescribing in the children's services world. Thank you very much to our panel. Thank you to Peter, thank you to Barney, and thank you to all of you for joining us this morning.
As Anne-Marie said, we are running the same presentation this afternoon, but if you have any thoughts or questions that occur to you during the morning, or you think this discussion might be interested to colleagues, then there is time for them to sign up before we go back on at 2 o'clock this afternoon. So just to echo Anne-Marie's thoughts, thank you very much for joining. May speak to some of you later, but do keep in touch. Thank you.
Thank you.
Goodbye. Thank you.